Well, it's an interaction between social and economic factors, healthcare, genetics, and individual behaviors. And they exist all together. You can't pull one out and separate it from the other. They all work together for health status. And the numbers will vary depending upon which sort of literature you read or whose opinion it is, but just to give you a general idea. So the social determinants of health don't change. They're by the World Health Organization, and they're the same as another lecturer has used before, but they are conditions in which a person is born, grows, lives, and ages. They're shaped by the distribution of money and power, both locally and globally, so on all levels. The social determinants are what are really responsible for health inequities, because all things really aren't equal. So to define the baby boomers, they were born between 1946 and 1964, so the oldest baby boomers turned 70 in 2016. But they still see themselves as young and essential. They are determined to stay young and hip and healthy. The boomers are the creators as well as the recipients of all the innovation and breakthrough that has occurred on multiple healthcare fronts, from less toxic cancer treatments to the whole new paradigm for emergency medicine. They're well-informed consumers of healthcare, and they are not going to sit back. They are going to take an active role in their care. Not all baby boomers are the same. There are young baby boomers and older baby boomers, and their influence, concerns, and values will differ just a little bit. Older baby boomers are more individualistic. They're much more focused on work, and they really want to make a difference in society. Where a younger baby boomer has much higher expectations, they are focused more on a balance between work and their family. And rather than being thinking about making a difference in society, they're more concerned about their own self-improvement. The oldest baby boomers graduated from college at a time when there was free love, and the youngest ones were in college during the Reagan administration. Another difference has to do with males. Older males experienced the draft, where there was never been a draft for younger males. In general, baby boomers have fewer children than previous generations, and because they have fewer children, that also means that as they age, there are fewer family members to help take care of them when they're older. They are better educated than prior generations, with about half of them having attended some college or having college degrees. Their household income is higher, but part of that has to do with the fact that you often have husbands and wives, men and women, two family incomes in there. Most of their homes are also paid for. They have a much more casual dress code than previous generations, and they are enamored with any sort of tech products. They own computers and spend hours on their computer. They don't have as much leisure time. They are more likely to be stressed at the end of the day, and they with Jane Fonda, are inventors of the fitness movement. So these are the social determinants of aging, and these are the areas that I'm going to be addressing in specifically for the baby boomers. And I'm going to start out by the truth. Baby boomers aren't quite as healthy as they or other people would think they are. Many of their jobs are much more sedentary than prior generations. When they commute to work, their commutes are longer, so they're more time in cars, and they do enjoy television, and so they sit and watch more television. Middle-aged baby boomers have less physical activity than prior generations. They also often enjoy soda or fruit drinks and those double cheeseburgers, so their diets aren't always quite as healthy. According to the American Hospital Association, by 2030, they're looking at 37 million baby boomers, which is 3 out of 5, managing at least one chronic condition. So I'm going to start with neighborhood and the desire to age in place. And a growing bunch of research focuses on the influence of the neighborhood. Characteristics like walkability, transportation, and safety affect a person's and benefit a person if they want to age in place. And according to AARP, we're looking at about 9 out of 10 Americans over 65 who want to age in place, stay in their home, stay within their communities. So what makes a place considered walkable? So physical characteristics that promote walkability, of course, are sidewalks that are in good condition, safe areas to walk in. And also when we talk about walkability, there comes up with the ability to talk to your neighbors. So there's a whole social aspect to walking around. Walkability is directly linked to better self-reported health, less reported disability, and lower obesity rates for people 45 to 84. Social aspect of it, older people who spend time talking to people when they're walking around are more likely to partially or fully recover from mobility issues. The conditions of the streets and sidewalk make a huge difference, especially if you're disabled or having any difficulty walking. Adults with severe impairments are 4 times more likely to report having difficult mobility if they live in neighborhoods where there's cracked sidewalks, potholes, no curbs, or curbs that are difficult to get up and down. The walk score indicates how walkable a community is. And I have no idea if I'm going to be able to pull these up. It's phenomenally interesting. You just go to the walk score site and you type in whatever you want to type in, and it gives you a score from 0 to 100. So I'll just kind of tell you this. First, I typed in where I live, Pittsburgh, Kansas. It had a walk score of 32. And I can tell you, we don't have sidewalks everywhere to walk in. When you type in Kansas City, Kansas, you have a walkability score of, I believe, about 37. But then you add in some public transportation, and that score was much higher. We don't have public transportation here. Ironically, I didn't think, because I don't live in Kansas City, that Kansas City, Missouri would be much different. But Kansas City, Missouri has a huge high score in biking. So not only are we looking at walking and public transportation, but biking. And Seattle, Washington, of course, is very high. Ironically, the one that scores the highest is New York, New York. And if you've ever been to New York, you know that no one wants to drive there, and everybody is walking and biking. So it's very interesting if you go out there to find out exactly what you score in your area. This is a very good visual about neighborhood features and how they relate to aging in place. Obviously, walkability. Interestingly enough, a diverse type mixture of residents. Not all people are the same. You know, there are from different races, different ages, and all that makes it much more healthy to age in. Accessibility to public transportation, safety, plentiful resources as far as parks, and good air. Let me also point out on walkability, it might be really, really walkable, but they do not take into consideration it's whether or not it's pretty where you're walking. So, which is kind of important for many, many people. So next we're going to look at aging in place as it relates to safety. Because whether or not a place is safe really is completely related to how much physical activity they get. And that doesn't matter what social economic background. They could be phenomenally rich, but if they feel unsafe, they're not going to be any more active than somebody from a lower social economic background. Seniors, in truth, have a relatively low criminalization group, but they have the greatest fear of crime. Even in areas where the crime rate is not necessarily very high, they still have an incredible fear of crime. And part of that has to do with television and newspapers, because that's what they do. That's what they start out with, lead with. And you can begin to think that is all that occurs within your neighborhood. If older adults think that it's crime-ridden, then they're going to believe it's crime-ridden. There's also a deeper vulnerability to injury because they don't feel like they have the physical abilities to ward off somebody. If their eyesight or their hearing is not as good, or their mobility is not quite as good as it was when they were younger, then that fear level is going to be even higher. Women have the greatest fear of crime than the general population, and it also increases when a person lives alone. So a widowed woman has the highest level of fear within her community. People who are afraid to go out will also be socially isolated, and when they need help for care, they're not going to have the access to it that they would in areas where they're walking around and talking to people. Transportation, when we look at transportation, those baby boomers began driving at a really young age, and they became more mobile than any generation before. So the ability to get around is really important to baby boomers. But eventually they're going to lose some of those driving skills. And who comes to the rescue? Automakers. And as soon as I say this, you're going to go, oh my gosh. They are banking on baby boomers to stretch out their driving as long as possible. They are giving us adaptive cruise control, forward collision warning, blind spot monitoring, and the self-driving car. So they have already thought ahead to us wanting to stay independent, wanting to drive, and lack of access to any sort of public transportation. Rural areas. 1 in 4 Americans lives in a small town or a rural area. But for many of them, aging in place is not always going to be possible, because often in rural areas, there is a lack of access to any sort of transportation. And I mean, even like a van to get them to the grocery store, to the doctor, taxi service, anything like that. There is less social interaction because people tend to live further apart, and access to health care is not always right in town. Often they have to go a ways to get any sort of health care other than just like at a clinic. There is a higher prevalence in rural areas of chronic disease, more disability, less healthy behaviors with a lower life expectancy rate. Immigration data will show that healthy older adults tend to live in their rural neighborhoods till about 75, and at about age 75, they will move to a more public, let me think of the word, a new, more populated location where there is easier access to physicians and all the other things that grocery stores, anything else that they're going to need. Young people for a long time have left the rural areas looking for jobs, and so it has made an imbalance between the young and the old. So as the older people age in rural areas, there aren't younger people around to help provide any sort of care for them. So it's very hard sometimes for an older adult to age in place in a rural area. Oops. Some older adults live in neighborhoods that actually make them sick. There are thriving communities that were one time thriving, and they are beginning downsizing, disintegrating, and they actually make older adults ill. But they don't want to leave their neighborhood because that's where their friends are, that's where they have such strong roots, and they really can't even see options besides living within their own neighborhood. There are also financial concerns. If you own your home, it's hard to sell a home in an area that's going downhill, and homes cost a lot more money than they did back when they originally bought their home. But often these communities are not safe, they're not walkable, they don't have good public transportation, and actually the fact that they've often lived in these areas for decades is actually very detrimental to their health, and it accumulates over time. Aging in place is usually a really good thing. It isn't always in areas like this, but it is a less expensive option for many older people when they consider going to any sort of nursing home or assisted living. Health. This is down and dirty and quick. According to the American Hospital Association, by 2030s, all baby boomers will be 65, and 1 in 4 will have diabetes. They're about half as likely to participate in physical activity, half as likely to have the ideal weight as they should have, as counterparts did in prior decades. Arthritis, by 2030, 67 million older baby boomers will have arthritis. with age being the greatest risk factor, as well as obesity and joint overuse. When you think back to young baby boomers, they're very adventurous, they're jumping out of airplanes, they're playing all kinds of sports, they're doing all kinds of physical activity, and their joints just bear the wear of it. There's not any way to completely guarantee you don't have any arthritis, but there are ways to delay the onset if baby boomers would go ahead and maybe lose a little weight or get a little bit more exercise. The Census Bureau says that about 27% of older men and 32% of older women are actually at their ideal weight. That's a lot of people in the overweight range. It increases or makes for a shorter lifespan. And also you have problems with mobility, but physical activity, lack of it, and poor diet has led to a huge amount of obesity. Dementia is a disease that affects many elderly, and it's slow and irreversible, and aging is the greatest risk factor. So we have more people aging at the same time, increased risk of dementia. Research doesn't really know why dementia always occurs, but baby boomers are at great risk because you got a lot of them aging. Older people with low social economic status who live in impoverished neighborhoods will face the greatest risk of poor cognitive function. Being poor in a poor neighborhood compounds the problems that lead to cognitive impairment. Barriers to health care. So boomers are living longer and they have more years to enjoy retirement, but they also are going to require health care for a whole lot longer. They'll also require different types of care, and they also need coordinated care because no longer is there just the family practitioner. You have the heart specialist, the urologist, the orthopedist. You have all these different areas that are handling one thing or another. And you would think that doctors would say, hey, this is a huge area. Why don't we look at becoming gerontologists? But for every 9,400 people over the age of 65, there is one gerontologist. And when you compare that to pediatricians, there are one for every 1,200 children under the age of 15, pediatricians that specialize. So we have a whole lot more interested in young than we do in this group of people that are really going to be prevalent. Baby boomers are not loyal to their physicians. I can remember my mom, the idea of her changing a physician was just inconceivable. You just didn't do that. Baby boomers are not loyal like that. In fact, when they do surveys, about 20% of baby boomers plan to leave their doctor within 2 years, and 35% have left their doctors within the last 2 years. The people feel like they're less connected to their doctors once they leave the office. So when they're in with them, they might feel like, yes, this is my doctor. But once they walk out of the office, they don't have that connection to a person like our parents did. You know, like this person really cares about me.
Hey, Debbie, Shirley had a question that I thought was really good and might be easily answered now. Why are fewer providers becoming gerontologists? Is it related to reimbursement, or is it just
Well, part of it has to do with the high number of them that are on Medicare and Medicaid. So yeah, and for many people, it isn't easy to find a doctor that will take them in. That's where small cities or rural were a little bit luckier. But in big cities, you have to call around to find a doctor that will accept the type of insurance that you're carrying. So yeah, the reimbursement is not near as good. And the amount of people that don't have extra insurance policies also are much lower. You know, parents will have family insurance when you're working, but once you're retired, it is much harder on a limited income to carry additional insurance. So that's a big part of it. Thank you. So anyway, they don't feel connected to their physician as well. And so providers are going to lose patients, and therefore they're going to lose revenue if they don't meet baby boomers' expectations. Baby boomers going to look at wait times, the interactions within the office or staff, how they communicate. What is their method for communicating with you? And they want them to meet their modern day expectations. So elderly patients often receive care from more than one specialist. So they want those specialists to talk. How many times have you been to a doctor and he wants to take blood, and you have literally just given blood 2 weeks ago to another physician, but the computers don't talk to each other. And it's very hard to get information from one physician to the other. I remember when I got a prescription filled out, a doctor gave me the prescription and he says, I'll fax it to your pharmacist, which was a couple blocks away. But the prescription actually goes completely out of state and then is sent back via fax to the pharmacy. That's how little our computer systems are set up for speaking with each other. The other problem is, because of poor medical reimbursement, they're discharging sick people sooner from the hospital. They get them stable and then they're out the door. And they are sicker and they need more care, but the insurance says, nope, their days are up, so that they're left to go. And then again, you have to have someone there to help take care of them. I find health care literacy and medical bills phenomenally interesting, because not only are older adults facing health issues, but the cost of health care is skyrocketing. And it's skyrocketed significantly more than the cost of living, as you can see on that screen right there, because you can see how it's gone up. Healthcare Services is a cost projection software company. So it says a typical older man that will live an average lifespan is most likely going to pay about $190,000 out of pocket for medical care during their retirement. And for a woman, because they live longer, about $215,000. So it's a huge amount of money that they end up having to pay, which explains why they often wait to go into the healthcare system. Not surprising at all, healthcare literacy not only impacts patient satisfaction and overall care, but it has a lot to do with compliance of whether or not they do what they're supposed to do when the doctor dismisses them when they're dismissed from their provider. Low education is the strongest predictor of healthcare literacy. and that is for both a sicker and healthier older adults. There's a big concern because older adults don't have sufficient knowledge or know how to use their knowledge to find out what are healthy decisions and how to be active participants in their health care. Typically, people with more education have better cognitive reasoning, and so they can figure things out a little bit easier. But I always find this kind of contradictory, because just because I have a PhD in history does not in any way, shape, or form I know what an abdominal aortic aneurysm is, any more than if they started talking to me in history sort of language, would I understand what they're talking about. So I think we also make the assumption that people with high education know medical terminology, and they don't. And so we need to adjust our healthcare literacy to make things understandable for people and ask questions, have them repeat the information so we can make sure that they understand what's going on. Suicide. Globally, statistics show that suicide rates are higher for older adults over 70 than any other age group. They don't plan suicide. They don't give warning. They often commit suicide. They don't tend to ask for help, and there are less attempted suicides and more completed suicides than younger cohorts. A term I had never, ever heard of before till I started doing this was the concept of rational suicide. And it is impulsive suicide driven by what is perceived to be an irreversible poor quality of health, not prompted by any psychiatric illness at all. This is healthy older adults considering rational suicide, desire to end their life, while they're able to do that physically and mentally. And so we are increasing life expectancy more than ever before. So it is harder for physicians to determine when no more should be done. Not when no more can be done, but when no more should be done. The difference between dying from and living with something. It's hard for them to draw the line. There is a failure for society and even physicians to be able to figure out where to draw the line, because so many people have the idea that they can stay alive without realizing the cost and what that actually entails. There's no longer a naturalness or timeliness of death. It's no longer taken for granted that you will just die because we can be put on machines that will breathe for us, machines that will keep our organs working. And for other people, they feel like their life is completed, that they've done all the things that they want to do in life, and that it's time to move on to the other world or whatever's left behind. There's a fear of loss of independence. And we ask students what they fear about growing old. They'll say they don't want to be a burden. Older adults don't want to be a burden, so they view rational suicide as a guarantee that they're not going to be a burden on their children or other people. As the number of people reaching later life increase, then we're going to see more people with alcohol and substance abuse problems. You got to remember that the baby boomers are the generation that experienced with and accepted the use of illicit drugs. And they're bringing that right with them into their older adults. Another factor is pain. There is more chronic pain, so there's more opioid use. People are living with chronic pain. They're not dying from acute illnesses anymore. There's
Debbie?
also, yes.
We have about 15 minutes left, and I think it'd be great if we had some time for questions, and Jill is here to tell us about continuing ed. So I'm wondering if you could maybe just kind of
Speed it up.
Well, just do maybe two or three more slides, and
Okay.
just pick out the most important. And
Okay. So anyway, older adults often use substance abuse as a coping mechanism as well. This is the suicide rates. You can see how they have gone up. Older adults, when we talk about transitioning into retirement, they are sandwiched by taking care of their parents who are also living longer. And a lot of baby boomers are also supporting adult children. They don't realize that how much they'll need to retire. Only 54% of baby boomers actually even have any savings account. They figure they'll just work longer if they have to. If they can't retire when they're 65, oh well, they'll just work on. Baby boomers don't necessarily want face-to-face communication. They want a phone call or text or email. They want choices. But when they see their physician, they do not want their physician to be in a rush. Older adults still have sex, but they don't use condoms. Part of that has to do with the fact that normal parts of aging, women are drier. But the biggest thing is we're from a generation where the fear was pregnancy. You can't get pregnant, so you don't have to use a condom. STD and HIV rates are very high for older adults, and Medicare actually offers them a free STD checkup, and only 5% of older adults are going to take advantage of it. Caregiving, the most interesting thing about caregiving is they are working towards better communication skills when a person is being discharged. And the CARE Act is an act that we have around in the state of Kansas that says that the caregiver has to be identified on the medical records, and they have to be trained to provide whatever medical care is going to be needed to take care of the person that they'll be taking care of. Let me talk really quick about the idea of non-compliance. I hate that non-compliance because it gives an idea that somebody chooses not to do something they should be doing. Well, rather it's misuse. If I don't understand what I'm supposed to be taking, if I'm supposed to be taking something 6 hours, something 4 times a day, I'm going to have a hard time. But the biggest reason is financial. If I can't afford my medicines, I'm going to break them in half, and I'm going to take half a pill because half is better than nothing. Or I'm going to take it every other day. Or if my wife has high blood pressure, I'm going to give her a high blood pressure pill on Monday, and I'll take it on Tuesday. So we have to look at why, and rather than labeling them as non-compliant, find out the reason they aren't able to take their medicines correctly. Social Security is phenomenally interesting because Social Security was enacted at a time when people lived to 61 years of age. The number of people that actually could take advantage of Social Security was small. You need about 80% of your income that you made when you were working, and Social Security will only cover about 40%, and that is given the idea that there are no cuts in Social Security. We don't have pensions anymore. There was a change that we are responsible for our retirement, and we're not doing a very, very good job about it. Let's see. Basically, what it all comes back down to is neighborhoods. The more disadvantaged neighborhoods, the worst outcome in healthcare, and that's where our focus should be when it comes to baby boomers. How about that? And then I love this little saying, so but I do have to read it. It's real short. Baby boomers are still independent spirits. They want to stay and age in place as long as possible, even if these clash with the opinions of doctors and experts who say the dwellings are made for young people and they are not equipped to accomplish a baby boomer's needs. They're going to stay where they are because they feel healthy and they feel young. And until they have chronic conditions, they are not going to change their independence. So, thank you.
Thank you very much. Okay, so let's take some, let's just take some time to have, if we could do maybe some quick questions, and if people have questions or just thoughts or implications. You know, if somebody has a burning question, do that now. Otherwise, we'll just go around and let everybody comment and ask questions.
This is Jill. I have a question, and I'm sorry, Debbie. I missed most of your what looks like to be a great presentation. Could you talk a little bit, maybe what are some questions that you teach your nursing students, or ways for your nursing students to ask their patients about their sexual history? Because that's something that can be uncomfortable for students to ask about, but it's really critical with the aging population because just from some of the statistics that you provided us.
Usually, because it is embarrassing, or can be potentially embarrassing, I have them say, tell me about your sexual activity. So it kind of opens it up for them to, first of all, it isn't any sort of, you're not accusing them of anything. You're not making any judgments about it. It's an open sentence. It allows them to fill in however they want to. If they are homosexual, it allows that to come in. If they are celibate, it allows that to come in. If they are taking singles cruises and having a good time like that, it allows that to come in. And if they say, well, I have sex every now and then you would say, are you using any sort of protection? Which they'll say, well, I can't get pregnant. That kind of opens the door for you right then and there. Well, you know, that's true. And isn't that great now that you don't have to worry about that? But did you know? That kind of stuff. You know, have you ever, maybe getting tested would be a good idea. That way you know for sure whether or not, you know, there's anything for you to worry about. Because you wouldn't want to spread that. No. You know, they don't want to cause ill harm to anybody. So they're usually pretty open. And you also have to be very prepared for anything they might say. You can't look shocked even if you are shocked.
Right.
Because some of them are pretty blatant with, you know, what they do.
Oh, absolutely. Yeah, absolutely. Well, thank you. That's really helpful.
You're welcome.
Okay, any other comments or questions?
Debbie, this is Shirley Dinkle, and I was wondering in your statistics and with the data that you shared today, if you saw any differences between straight baby boomers versus LGBTQ plus baby boomers.
I did not look at that.
Okay.
And to be honest with you, going into this right off the bat, I didn't have any idea there'd be such a difference. When I type in baby boomers, it is very specifically heterosexual.
Mm-hmm.
And had I had more time, I could have also gone into that. But I would definitely think that there would be, because the older group, what are they above us? The depression, is that what they're called?
Mm-hmm. Mm-hmm.
Yeah. The idea of getting married, of course, is totally foreign to them, where baby boomers will have been married.
Mm-hmm.
You know, so it will be a completely different generation of LGBT baby boomers than in the depression area, because we will have grown up in a whole different, or aged in a whole different area.
Mm-hmm.
So, phenomenal, good idea.
I think maybe you and I should do some research when you retire.
Yeah.
I think that'd be great.
It would be so fun.
And it's such an important issue. So, I do think there's some stuff to be mined there. Just like you saw the difference between younger and older, I think there's particular concerns that you could dig into that relate to cultural competencies of all different kinds.
Yep.
Any other questions? We have time for a couple more or comments. Pamela, do you have any thoughts? Or okay, I'm not trying to push any. Lauren, did you have anything? Or Megan? Just if anybody has questions or comments.
Jill, this YouTube thing right here is about 4 minutes long, and it is older adults, and it's rap, and it has to do with condom use, and it is really, really good.
I'll copy that see if I can copy that. No, but
it should be embedded on the slides.
It is, yeah. And I'll get the slides to Jill as soon as. Well, you have sent her the slides, right? And then we'll also have the video. So I started it about a minute late, Jill. Yeah, I'm wondering about, just some advice that you have about people who are care providers, medical providers, nurses, whatever. Just, that was really great about the sexuality. But I'm wondering if you have other comments or examples or stories that you have of, talking to people about, suicide, or talking about, how the caregivers or medical professionals need to be communicating with social workers, or just, it's really kind of a different, there's setup than with younger people in many cases. The need for care after they leave a facility, or the issues when they're going to the doctors, and how you follow up with the things the doctor or nurse sees.
I think part of the problem is we send people home to provide care, and the person is responsible for everything. They're responsible for doing tube feedings, shots, colostomies, responsible for all that, including transportation, everything. Then they bring the person to the doctor, or they get into the hospital, and we ignore them. Like they have no knowledge, could provide us with no good information. and aren't in need of any sort of help of for their own well-being. But I mean, who knows better when the person receiving care likes to eat, how to best get them to the bathroom, how to best move them from point A to point B. They have all that information, but yet we tend to ignore them and not make them partners with us. We tend to just kind of ignore them. And how often do we ask, well, how are you doing? Respite care can be for half a day, it can be for a weekend, it can be a month. And how do they know about respite care? You know, we don't like to ask for help, but it's amazing when it's offered or when it's suggested, and they try it, they find like, oh my gosh, being able to spend the morning grocery shopping and getting my hair done makes the whole week so much better. So I think we need to include them.
How does that work with HIPAA, though? You know, the private stuff. I mean,
well, they can be put on the HIPAA list so that anybody could have access. Yeah.
I think, you know, as I was hearing you talk about that, it's this idea that, you know, it's when the patient, when individuals come into the healthcare system, they're coming into our territory, for lack of a better word, but that's how it feels. And it's, you know, it's like we forget that this person has come from a family, has come from a community, and that caregiver coming with them is so incredibly important to understanding what's been going on in the community and has the needs of their own. And so, you know, that's one of the beautiful things about community-based nursing or care, is that we're going into their community, into their home, and we get the entire picture. And so we need to be more mindful about that when people are coming into the healthcare system, I think. And yeah, I'll get off my soapbox.
I can kind of.
I think that's a really good reminder. Thank you, Debbie.
Yeah.
I experienced a situation where my husband was diagnosed with cancer. I lost him about 7 years ago, but it was really apparent to me that I was nothing in the system, you know, and I was caring for him. I knew every detail about what we had walked through, but there were many healthcare situations, times I felt like I was thrown against the wall. They would go at great lengths to find answers to things that I already knew the answer to. They didn't want to hear it from me.
I think
that. Why is that?
It was very tragic. I mean, to me, it was very disappointing to me because I felt like the healthcare system within which I worked was letting me down.
So I've had patients who will take their medications from the caregiver, piece of cake, but won't take them from me. Heck, let them give them their pills. I'm standing right there. Why do I feel as though I can't do that? You know, it is so disrespectful to the caregiver.
Absolutely.
I think we have to change some kind of our approach in some way because, you know, I think we've gotten so into you have to hear what the patient's perspective is, but, you know, we really have to emphasize that that patient is bigger. It's part of a bigger system, and the whole system is involved in that issue. And it was quite the eye-opening experience to me.
Well, Pamela, we're going to have a follow-up session next Thursday at the same time at noon. Oh no, I think it's at noon.
Yes,
noon, where we can get into some of these, and maybe we can pull together with some of these ideas and have some more discussion, find some models. There might be models of places that are really beginning to include. Jill, it sounded like maybe you had some examples of community care. So we'll be sending out an invite for that. It'll just be an open discussion, and I think it'll be a great opportunity to dig into this a little bit deeper. So with that, I think, Jill, unless you have some words to sign off, we'll end this call, and we will be sending out the recording as soon as we can get it.
Yeah, thank you all so much for joining, and thank you again, Debbie, for sharing your expertise and your passion.
You're welcome.
Right.
My
Debbie.
pleasure.
I really
presentation.
enjoyed it. I'm not even in healthcare.
Yeah.
I
I really enjoyed it. It's great information.
Thank you very much.
Thank you so much.
I truly enjoyed, first of all, I love research, but I was blown over with what I learned. And I will be incorporating a little, and baby boomers in this area into my lectures. So
Great. And if you join us next week, that'd be great. Okay.
I am in
Have a
Florida.
wonderful rest of the week.
Thank you very much.
And Jill, I do apologize for losing the first, like it was before we got started, but anyway, I did, I'm just like, I tried so hard to remember. So I'm saving it on my laptop, so I'll just upload it into a folder.
Yeah, that sounds great.
Good? I'll just, we have a folder. Do we have a folder? We have a.
Yeah, we do.
Okay, I'll put it up there. Anything else?
So I got all of the names.
Oh, here I have, you can go down there in the chat, and I don't know, but maybe I'm going to do that right now. So I'm saving the chat. It's got all the emails in it.
Oh, good, because
You didn't see that message from me? Yeah, see, what happens is when you get on late, you only see the chat from when you got on. It's an annoying feature.
okay.
I saved it. I'm gonna send that to you immediately.
Okay.
And then as soon as it will take, like 15 minutes or whatever for the download to happen. And
Okay.
and then just next week, wow, it sounds really like we might have some interest. So if you send we're having an open discussion on that again, and maybe we can get Debbie to come again. And there's a lot of great information. I really enjoyed that.
I know, it sounds like it was really great. So yes,
don't you? But she has a lot more that wasn't on the slides. And that was so really great. Yeah.
Okay. Well, I'm going to, I will send an email out or an appointment out with, for next Thursday.
Okay, great. And let's see, now where's this chat? It's not showing up for me. Here, I'm gonna get this save chat. Save chat, and chats is saved. And now it should give me the chat, but I have too many things open. But I have another call I've got to hop on right.
Okay, so yeah, well,
I will
I'll
get
look
it
for
to you
that.
tonight, okay?
Okay,
Okay, take
thank
care.
you. Have a great
I
day.
got to end this.
Okay.
Where is it? Now I've lost. Oh, there it is.
I think when you leave meeting, you'll end it for us.
Okay, yeah, that's what I'm doing. I just couldn't find it. Had all of these other things. So, okay, take care. See you next.